Okay, hello, good afternoon everybody. Welcome to our monthly Community Mental Health Transformation webinar. I'm Megan G, the Communications Manager supporting the programme. Really good to see you all today. We've still got some people coming in, but we will make a start as we haven't got a great deal of time and we want to cover quite a lot today. So this month we're going to be looking at the learning from other parts of the country and how they've tried to kind of take on the community mental health transformation challenge, and how they have approached it, and how we can learn from that in our approach in Sussex. And today we're joined by Oliver Dale, who is our clinical lead for the community mental health transformation. And some of you might not have met Oliver yet, so it'll be an opportunity for you to meet Oliver and to find out more about his previous experience. We're also joined by Nigel Everson, who is our Interim Director of Programmes for the Mental Health Collaborative. And again, some of you might not know Nigel, so it's an opportunity to obviously meet Nigel and hear about his role and the work with the programme. And we're also joined by Martin Dominy, who is the VCSE Mental Health Transformation Lead for East Sussex and Brighton and Hove. Martin joined us for last month's webinar, so there's a familiar and friendly face, and will be obviously speaking to us about some of the learnings from the VCSE perspective in the transformation and what we can look to take on in the work we're doing in Sussex. So before we get going, just a little bit of housekeeping. We are going to be running the webinar slightly differently this month, following some feedback from some previous attendees that they would really like to be more involved in the webinar as a whole, and not just given the opportunity to ask questions at the end in the Q&A. So what we've done is this time, attendees now have the opportunity to have their cameras on. You can also use the hands up function, and we're able to get much more of a sense of kind of who's in the room. You're able to obviously share, your suggestions, your questions by using the chat box and also the Q&A box. But because this is a recorded webinar, we just wanted to highlight that obviously if you do choose to have your camera on, it will be included in the recording as well as your name. So and the recording of this will go onto the transformation playlist that we have on YouTube, where we hold all of our previous webinars. So whilst we do really also encourage you to, get involved, have your camera on and get in the conversation today, we do understand that some people might not feel comfortable to do that. So do feel free to keep your camera off if you would prefer. And you've also got the option of turning on live captions. If you click the 3 dots at the bottom of your screen, that will then give you the option to turn on captions if that's helpful. And as usual, there will also be a designated 15 minutes at the end of the webinar, which will be specifically for questions and answers. So we'll make sure that if you do have any questions, there is an opportunity for you to ask them then. And as we do usually, a summary of the topics covered will be sent round by email later on this week, as well as a link to a short survey just to capture your feedback, which is more important than ever as we're changing the format this time. So if you do find that it works better for you, or actually if you prefer the previous format, do let us know, because we're always, looking to, change and adapt these to make them as useful as possible for the people who are attending the webinars. So the last thing from me is just a reminder, as I alluded to before, we do record all of our webinars, so if you have missed any before, or there's ones that you really enjoyed and you want to watch them back, we do keep them all available on a YouTube playlist, which is available at the QR code on the screen, but will also be emailed round to you with the supporting notes after the webinar today. So hopefully that will be useful. So I'm just going to make sure that everybody's been let in from the waiting room. Yep, we are all good. Okay, that's brilliant. So I'd now like to introduce you to our presenters for today. So we've got Oliver Dale, Nigel Everson and Martin Dominy. And we're going to start off the session today with a bit of a panel discussion, which Oliver and Nigel are going to take part in, and then Martin is going to share a presentation with us after that. And we thought this would be, quite a nice way for you to get to know Oliver and Nigel a bit more in the roles that they're doing within the programme. But also they've both worked on community transformation in other parts of the country. So we thought it'd be really interesting to find out a bit more about what their experience has been and what we can learn from that in Sussex. So I am going to stop sharing my screen so I can bring us all back together. And I'm going to put a spotlight on Oliver and Martin. Sorry, Oliver and Nigel. Martin, you get to have a bit of a break before your presentation. So to start off with, Oliver, would you like to introduce yourself first, and then Nigel, if you'd like to do the same?
Yeah, sure. So thank you, Megan, for the warm welcome. So my name's Oliver Dale. I've just started in mid-May as the clinical lead for adult community transformation in SPFT. My background is as a clinician. I'm a consultant psychiatrist, and I'm also a psychotherapist. I've done a Jungian analytic training as well. And I've worked in community mental health services as a consultant for about 15 years in West London NHS Trust, largely based in Hammersmith and Fulham. So I'm really very new to the area. But I'm very familiar with working in community mental health teams. So over to Nigel.
Yeah, thanks, Oliver, and just again, yeah, thanks for the welcome, Megan, and good to see so many people. I'm Nigel Everson. I started in Sussex a few months ago in around October time. But I come immediately from Southwest London and supporting the ICB and ICS developments there across a range of adult and children's programs. And one of them included the community mental health transformation bit as well. And historically, I've worked mostly in mental health, but not all mental health. I've done a variety of roles, both for the NHS and also integrated roles with our local authority colleagues. So had lots of joint roles in the system, but also done some really diverse stuff as well. Even, you know, roles such as head of healthcare in prisons, so Brixton and Belmarsh, for example. I've worked as a commissioner and set up a lot of procurements around health and social care provision. Worked in older adults, children's services, as well as core adult services. So I'm not an expert in anything by any means at all, but I know a little bit about everything. I mean, you asked me about dentistry, optometry, ask me anything, and I know a little bit. So I'm always good to invite to parties. Thank you.
That's great. Thank you both for introducing yourselves, and it's brilliant to have you with us today so that we can kind of pick your brains a bit and learn a bit more about what your experiences has been around, you know, specifically around the community mental health transformation, and how, you know, obviously we're all trying to tackle this across the country, and there's obviously been different ways and different approaches in how different areas have chosen to, you know, kind of take this on. So we're really keen to obviously hear kind of your reflections and insights on that. So Oliver, I wondered if you wanted to get us started in, you know, what has your experience been of community mental health transformation in your previous trusts, and yeah, what we could kind of take away from that.
So my involvement in the community mental health framework goes back quite a long time, actually. I was a national advisor to NHS England, particularly focusing on the complex emotional needs part of the pathway. And I was also an advisor to the National Institute for Health Research's Mental Health Policy Research Unit's project on complex emotional needs. We did a mixed methods evaluation of service design. And I also co-edited the Royal College of Psychiatrists position statements on services for people diagnosed with personality disorder. So I've had quite a lot of conceptual investment, if you like, in the transformation. So I was really pleased when my NHS previous employer became an early implementer site. because as a psychiatrist, I was really keen on developing or seeing develop what I think of as a psychiatrist, I call it social psychiatry. This is very much a social model of care. So my organisation became an early implementer site, and we were sort of working on our model in the run-up to the pandemic. And then the pandemic came along and sort of was a major disruption. And it actually did have quite, I think, a bit of an impact on the model that we developed. And I'll come to that later about what worked well and what didn't. But in short, I was the clinical lead for Hammersmith and Fulham Community Adult Mental Health Services. So the ATS teams, as it's described in Sussex, and also the primary care service, which is a bit similar to the emotional wellbeing service here, and rehab. And so I was responsible for all those services in Hammersmith and Fulham. And anyway, and my role was to support the development of the practice and the establishment of that practice of the new model, which we called the Mental Health Integrated Network Team. And we created 5 of these teams, which integrated primary and secondary care in our borough, and there were 3 of them working with 5 different primary care networks. I hope, Megan, that the language I'm using is familiar to people. I was also working clinically in one of those mental health integrated network teams as well. So I was both poacher and gamekeeper, if you like. But I got to see effectively, I had an experience of it, but work clinically, but also from a leadership point of view. So I was sort of quite in the midst of it, and it really involved a good couple of years of my life in a very intense way. And we went live, if I remember correctly, almost 2 years ago today. And it was a 3-year program. So I saw it through to the first 2 years before coming to Sussex. So I can tell you a bit more about that in a moment. So I'll hand over to Nigel now, though, if that's all right.
Yeah, no, thanks, Oliver. So in terms of my involvement, it was very much around supporting our local mental health trust and our partners in terms of putting together what we proposed to do around community transformation just over 2 years ago. And like Oliver's, in terms of West London, it was very much a 3-year programme. Within South West London, you may or may not know 6 boroughs, but the approach was very much about just focusing on one borough initially, really to look at what we meant by all those lovely things we were writing down about how seamlessly we were going to make everything work and how painlessly it was going to be for people to access services and be put on the right pathway, regardless of what the presentation was. So we really focused on one borough, which was the Sutton borough. But again, it was very much about trying to understand what already existed there before we thought about, well, actually, what do we need to do? Because every area, and it's very similar in Sussex, isn't it? But every area is very different, and every area has different players, different relationships, different elements of resource as well. I mean, in my old phrase, in terms of the old commissioning arrangements, it always depended, what you had locally as a resource often depended on, obviously, what the resource available was to that local area. Some areas are much wealthier than others in terms of their reserves and what they can offer, but it also depended on how deep the pockets of the local commissioner was and how big their heart was in many cases. So there was a real disparity of resources that were already within those different areas. So we focused on Sutton as the first, and what the intention was is that the learning from there would then obviously be implemented and built upon as we move through the other areas. So that was very much what that was about. But in terms of my role, it was very much about trying to make some of those relationships and try to understand where people were and how they wanted to work together. and then really to start planning how that would take shape and who needed to have the conversations. I'm absolutely delighted that Oliver's here because it was a key component. I know we're going to talk about the sort of learning for Sussex, but it was a key component because it is a lot of this stuff, as people will know as well as I, it's about relationships, it's about connections, and it's about having some of those unofficial conversations in order to get some agreements to progress, to move on. So it's a real key bit is that clinical leadership for me. So my experience predominantly around Southwest London, but as part and very similar to what Oliver probably done as well, just went round other areas and just look what other areas were doing and what some of the learning might have been for them as well, and some of the proposals that they were putting in and what they thought might be able to be achieved. So really trying to take some of that learning, and we joined a lot of regional and a lot of national discussions about what this meant. I think for me, and again we'll go on to learnings, but it wasn't just from an NHS perspective, it wasn't just from a programmes perspective, it was about our community locally. We already had local place-based leadership groups, and it was very much about that leadership group taking ownership of what this meant, not only for mental health services, but the impact that would have on other services, such as our local authority colleagues, such as primary care, etc., and our acute hospitals. So it was very much an engaging conversation before we put our plans into place.
Thank you, Nigel, and thank you, Oliver. I think already it goes to show that just kind of in two parts of the country, the different approaches that can be adopted in this. We've all been given the same kind of task to do, but there are lots and lots of different ways to actually approach this. So what I'd be really interested to know is, what were the positives? What were they doing well? What are some of the examples of things that we could look to adopt and take on board in some of our work in Sussex? I'd be really interested to hear kind of what your reflections were on that. Oliver, do you want to go first?
Sure. So I think my reflections on what worked well and what worked less well has something to do with the context within which the model was developed and established. So you've got to remember the timeline here. So we had been starting to have conversations with our local stakeholders and partners, and then the pandemic came and boshed that on the head, really. So we then, that became very disrupted, and what ended up, but we then had to, after we sort of picked ourselves up from the start of the pandemic, we then started to work again on the project. However, the local partnerships and relationships were much more limited than we started out with. So effectively what happened was we had the focus ended up being much more secondary care into primary care. And the other important part of the context is that we already had very well established primary care mental health service with a full MDT working across the borough. So the context was pretty different. But what worked well, I think, in short, was I think we ended up with a very integrated primary and secondary care service where referrals would come in to us, and we from the whole range of mental health need and risk and severity. And I think we did genuinely end up with a really healthy mix of different interventions that we would offer our local population in terms of interventions such as social prescribing, peer support, and so on, before they might end up having a care that might traditionally be described as CPA care, with a psychologist and a nurse being allocated as a care coordinator. So there's a much more of a recovery-oriented approach, I think. The other aspects of the integration was that, certainly my service, we begun to co-locate ourselves in the GP practice. And I have to say, clinically, that was one of the most exciting things that I did. I really found my practice changing in terms of offering further follow-up or not, or in terms of we would have, GPs were much more comfortable in dispensing depot antipsychotics, for instance. And so I would sometimes just see a patient with the GP, and we would agree that we would restart an old depot or change to a more longer acting one, and without the patient coming into the secondary care service in a more traditional way. So practice was hugely changing for me. So that was very exciting as a clinician. The other thing that was really exciting was we developed what we called the shared care space, where we really sort of broadened the concept of team, and it really did become a network. And so every week so in my particular clinical patch, we had 6 GP practices. And every week our team would focus on a particular practice. I would literally go there and sit next to the GP, or if it was a nurse who was the lead in that practice, or one practice actually had a pharmacist. And we would go through, we have a 90-minute meeting with the network, and we'd have IAPT there. One of the teams had Turning Point, which is our drug and alcohol service. We have psychotherapy there, the psychologist within our team. And it was some practices really liked to engage in the development of formulation and relational practice. And so we have these wonderful conversations between IAPT and psychotherapy and so on, sort of rattling around. And you could see our colleagues in primary care just observing, listening, and really thinking differently about their role, but also when that you might need a psychiatrist, or if a patient was asking for an intervention which was probably unrealistic, the GP was much more able to engage with the patient in a much more human-to-human way, and sit with the suffering that sometimes is very difficult. And sometimes we offer interventions when we don't really believe that they're the right thing for them. But it's just a way of managing the distress and the anxiety, is to offer something. And so I found that the relational depth, if you like, really changed. So that was very exciting. The other thing, there were the other things sort of around the edges, though, which I think were quite interesting. So although it's one of the things that did not work well, one of the things that did work well also at the same time was we adopted System 1. So people don't know, so it's one of the electronic patient record systems. And we had RIO, which is the sort of typically secondary care one, and we took on System 1, which is typically a primary care one. And it was a real game changer. Because the GP could see in real time when we had triaged the patient what our plan was. And it also helped with things like conflict and confusions. So if a patient missed an appointment or cancelled, the GP could see that was what was happening. They could see our attempts at trying to find them, and they could support our attempts in trying to engage patients as well. So instead of it becoming a source of conflict and antagonism, it actually became a way of engaging with people. And although some people might sort of balk at this, certainly if they're operational. So when we started the model, it was sold as a way of discharging patients to primary care. And in actual fact, our caseload went up quite considerably, but the churn went down, our referrals went down. And so there was less sort of, a lot of time is invested in working with triaging and offering assessments and managing DNAs and cancellations, etc. An awful lot of energy goes into that in a way which is not particularly helpful. So the nature of the caseload, I think the nature of the work changed within the caseload. As I said, the caseload actually went up, but actually as a consultant clinically, I was much more happy with that. And particularly as I had all sorts of other different colleagues working with me. So I wasn't seeing loads more patients. I just had lots more staff working with me, and so there was a sense of something not being quite so on my own, I think, as well, with sometimes very complex and quite anxiety-provoking situations. I had a much greater partnership in terms of the GP or a peer support worker or what have you. So I have to say, it was clinically an extremely exciting time. There were clouds, though, and I'll talk about those in a second. But actually, it was I really hope that actually some of my colleagues will begin to experience some of the changes that we made, because it was really inspiring. Over to Nigel.
Yeah, no,
Thank you, Oliver. I'm very mindful of time. I want to make sure that we get the opportunity to hear Martin's presentation as well. So, Nigel, if you would be able to kind of share kind of the top positive things that you experienced.
Absolutely. Lots of the things in terms of what people experience in terms of clinical practice and the support networks rings true of what Oliver said in the Southwest London bit as well. And I just think what worked really well was something around not only looking at it from an NHS perspective, but looking at this about who else did we need to support. And I mentioned our local authority colleagues earlier, our VCSE colleagues, and actually we put together the secondary care, the primary care, the IAPT, and we brought in our VCSE colleagues as well in terms of they had referrals going to their services, didn't quite know what to do, and our mental health teams within the local authorities equally. The other significant thing that worked well is we looked at the 18 to 25 bit as a specific cohort, because the context around children, young people, and you know, that preparation for adulthood, the work that's been done there, and then when people come in at 18, there's a context that was really helpful for people to acknowledge and therefore to base their next steps on that context, if you like. So there was a real joining up, and we had people from SEND teams, you know, from education, etc., joining in the conversation in terms of what does that mean for them when people were in further education or in apprenticeships or you know, first sort of stages of employment, etc. So that was one of the things that worked very well. The VCSE were absolutely significant in, because and in the same way, hopefully, that people have seen how our VCSE colleagues here within Sussex are doing, but often people don't trust the NHS or they don't trust the local authority in quite the same way as in terms of expressing their views and their wishes. So the VCSE in Southwest London very much joined forces and became that conduit with some of those more tricky conversations. So that was really, really significant. And just to close in terms of the real positives, was the Mental Health Trust within Southwest London really did lead this programme of work and the relationships. And because without that clinical and operational leadership and willingness to change how they support that system, it wasn't going to work. And that's very much what's happening within Sussex now. But it's crucial. I think people often underestimate it. It's absolutely crucial.
Thank you. I think there's some fantastic, you know, kind of highlights there as to what was going well and things that obviously we can be, you know, incorporating into our planning in Sussex. So it's going to have to be a bit of a quick fire round. But Oliver, if you were to kind of share, I guess, kind of the main thing, that the main challenge that you experienced, something that maybe didn't go as well, that we could try to avoid in our work.
So we did a big bang approach because we had to, and that was probably, well, it was very hairy, and someone said it's a bit like building a plane whilst flying it, and I think that's probably the best way of summing it up. I don't think that we'll have the same issue here, simply, as I said, because the context that we were in at that time. But that was a big issue, and the other big issue was IT. And we had two record systems at the same time. We had not clocked. We just hadn't thought about. Well, we were told that we would have an interoperability thing, gizmo, allow the computer systems to work together, and which I spoke to Joe Hillier yesterday about this, so I don't think we'll make a mistake. Yep. Over to Nigel.
Thank you, Oliver. And final thoughts, Nigel.
So mine is everybody's obviously interested in the model. What is it? What is it that we do, and what is it that, and how are we going to do that, and how are we going to deliver it? But for me, that there is a massive piece around the infrastructure. So Oliver's mentioned IT, but comms is a massive thing. And one of the things that we have to make sure is all the conversations that we have, they get stopped at times, and we just recount in terms of what those actions might be that have come from those conversations, and make it stick, because it does seem that often conversations can be circular. So unless you've got that infrastructure around to support the program moving forward, then we won't get very far, really. So we must remember all the people that work in the background that you don't see, other than the clinicians and operational managers. There's a lot of other people that support this, and they're equally important to make that work.
Thank you both, and sorry to have to kind of rush through. Was very keen to make sure that we have the opportunity to hear from Martin, and also to give people opportunity to ask questions at the end. So we will come back to Oliver and Nigel in the Q&A, but for now I'm going to hand over to Martin Dominy, who's just going to share some kind of highlights of what we've learned in other parts of the country as well. So I'm just going to bring up the slides.
Thanks, Megan. I just want to say it's been really good. I've been really enjoying listening to Nigel and Oliver as well, and bringing that experience in. It's been really beneficial. So I think, Megan, thanks for the kind of introduction as well. So I'm kind of one of the VCSE reps, as you mentioned. Ours is really to aim to kind of strengthen and embed the VCSE, as Nigel kind of alluded to, the importance of all these other partners and providers to be kind of really part of the programme, but also kind of working really closely with a couple of people on the call, Jonathan and Penny, for instance, around kind of model design and how this detail is going to come out about what the service is going to look like in the future. And again, it's just that reflection. One of the really nice things around kind of working in this health sector is kind of people's willingness to share. And I think that's really kind of brought a great value. And as we are kind of sharing with others about what we're doing and how we're working, how we're kind of addressing problems as well. And it creates a really nice atmosphere that people feel safe and able to really kind of impart information to each other and kind of help each other along as well. So Oliver alluded to kind of this big kind of plan has been running quite a few years now. There is 12 trailblazer sites that were kind of identified across the country as well. So we're kind of just working through that kind of list, looking at kind of what areas have been kind of taking services forward that really kind of chime with kind of Sussex. I know we've got West Sussex and East Sussex and Brighton, so they're slightly different in a way. But so we're kind of like approaching people and having those really kind of in conversations about kind of what we can learn as well. And again, it's that early reflection of what Oliver mentioned, that some of this work really got hit by COVID as well. So the idea that these sort of 12 trailblazers will probably be further on than sort of the reality of it is at the moment, but they are kind of catching up as well, because it did really kind of impact them as well. So they're the kind of people that we're kind of looking at. So what we're doing, if I can have the next slide, Megan, is what we're actually doing is to do a sort of a deep dive on some of these kind of places as well, and then start to really pluck the kind of key information as well. So some examples here around Cambridge, Town Hamlets and London as well. And it's just some really kind of key learning that they kind of shared with us about the branding, identity and access, and that move away from kind of non-medicalized kind of support offer as well. And a very kind of clear way of actually people accessing the information. So it's a lovely thing from Cambridge has got, and that's what they've called their title. It's like, how are you? So it's just a really welcoming. So it's getting away from that kind of like sense of mental health services and national health kind of thing, and actually just asking people in a really kind of open, transparent way as well. Town Hamlets is kind of that language is important, and Megan and Jonathan Meader have taken that kind of learning forward and started some really brilliant work about how we use language, how we kind of put information on forms as well, and how that makes it much more kind of welcoming and inclusive of people as well. Some real common things that we see time and time again, this kind of move away from referrals into warm introductions that everybody really kind of wants to do as well. So people don't feel like they're a burden or having to wait for different parts of the kind of support or care they might be kind of receiving. It's actually kind of very seamless as well. And one team, and we're talking one team, we're talking very much in terms of one team in the VCSE, people with their own lived experience, and kind of statutory kind of health and local authorities, as Nigel's mentioned as well. And Liverpool is another example about how they've managed that anxiety or that kind of that real focus around when somebody, from a GP point of view, kind of sees somebody's at risk, or they have a floating worker. So it's just bringing all those things into our model design as well. So one of the kind of the real kind of sort of areas that are really ahead of everybody that actually kind of really just took COVID on the chin and said we're not going to let it stop us, and kind of really went for it, was around Somerset as well. So there's kind of a rethink from the VCSE point of view, but also kind of the statutory services as well. So they've been a little, ahead and been really, really generous of sharing their information as well. So they had an open day recently. And so they kind of shared some of their experiences as well. They're important, as Nigel mentioned, the importance of relationships. This is not always about processes and systems. It's actually people working really closely and are trusted in kind of really respectful kind of way as well. There's cultural change that needs to happen across the VCSE, across kind of into kind of that system-wide kind of culture as well, and actually just making it kind of much more kind of welcoming and challenging as well. So there's a kind of a list of resources that kind of go, really kind of go at it kind of attitude that they really have, and the willingness to make mistakes. And that was really nice to hear. Actually, they have made mistakes. They've learned from their mistakes, but making mistakes isn't the thing that's held them back as well. So that was a real kind of code, really important kind of aspect. And again, at the open day, there was really kind of sort of well represented people that kind of had used services or currently were using services, their experience, and you could see the whole way of their development. Actually, they had a really strong kind of voice of experience through their program as well. So that's the kind of our first kind of enablers as well, but they kind of went into much more detail about their kind of, their real focus on the governance. They did commissioners really kind of let go. And so they kind of said, okay, there's representatives from the local trust, VCSE, you're going to make decisions, you're going to make recommendations, and we're going to back you. So it's a really different cultural kind of landscape they managed to develop as well. And some of those other things that we've mentioned already, but I think it was just making sure that how people experienced the service felt very different. So you had one story and you told it once, and you didn't really feel like you had to keep repeating it, because there's evidence that sometimes somebody has to repeat their story 10 times before they get the actual support that they kind of need as well. So just conscious of time, Megan, so I'm kind of happy to go on. Part of the kind of the beauty of being a trailblazer was there's extra resources that brought into. So they still have a kind of really close link with Plymouth University, who are doing an ongoing evaluation and research. So every time they make a change or they suggest a change, the researcher can be there kind of walking that journey with them to actually saying, well, what's the impact? Is this actually benefit? Can we see we're not just pushing the burden of actually higher caseload onto different parts of the system as well. So it's a really intelligence-led kind of planning and kind of implementation of their model as well. They developed local hubs, which we're kind of looking at, that kind of neighbourhood work as well. They've got some really great kind of work going on in sort of the local GPs. The alliance, the VCSE's alliance is growing. So there's a number of partners that came in, but actually now they've actually doubled the amount of people that are funded through the program as well. They've kind of, I'm sure this is heard many times about this no wrong door. So there's this single access, but there's many kind of points of access, but everybody kind of has that kind of joined up assessment going forward as well. And then what's really kind of comes over is actually everybody gets support. So it's not about how unwell or how well you are or what service is available. Everybody gets offered something as well. And an amazing kind of impact on that, again, really kind of pinned by the researcher, really, is 90% of people are seen in 4 weeks. There's a reduction in A&E as well around kind of mental health. Some really positive outcomes for the people using the service, but also the system and how they can kind of reinvest its money so it doesn't spend so much money on urgent and crisis, so it can invest more money in kind of upfront kind of prevention work. So some really good kind of outcomes for those guys as well. So there's some key takeaways. I'll pass on that, Megan, if that's okay, but please do come back to me as well. And what NHS England have also kind of been doing and is actually starting to pull some of this kind of the learning from around the country back into. There was a recent conference that Penny Fenton and Ian Dyer went to as well. And so these are some of the kind of key themes as well. But one of the things I just wanted to say just before, because I know you can all kind of read the list really, it's just to actually just admit, just being honest with this. This is really difficult. It's really complex, but don't give up and keep kind of going. And I think that's a really good kind of message as well. We've got a really good team in Sussex, and everybody's really committed to this kind of work, really. And I think there's real momentum now as well. So I think it's just, there are challenges and there are kind of difficult times, but I think it's just keeping going, really. It's a really good message for everybody. Thanks, Megan.
Thank you, Martin, and sorry to make you have to race through that. We will be sharing all the slides after this. You can read them in more detail. And obviously, if you do have any questions about that, specifically for Martin or for the programme more generally, do get in touch with us. All of our contacts will be included in the email we send around. So I'm really keen that we can get on to some questions. We've had a couple coming into the Q&A box. We haven't got a great deal left of time, but obviously people are very welcome to stay on if you're able to for a couple of minutes. And we'll see how many we can get through. So I invite Oliver, Nigel and Martin to form our Q&A panel for this. And our first question is from Jim, who said, do you envisage different models of delivery being offered in different areas, considering the rural and urban differences that we have in Sussex? So I don't know which one of you would like to jump in and answer that.
I'm happy to start. Sorry, all of you who both jumped in at the same time. I was just going to say, I mean, from my perspective, but from the programme's perspective, that there are key things set out in terms of themes and outcomes that we want to achieve. How that's delivered will depend on where it's being delivered. So by its very nature, I think we have to look at slight variances in the model. But keep that sort of true connectivity in terms of what our aspiration is, if that makes sense. So very simply, the answer that I think is yes, there'll be slight variances.
And if I could sort of expand on this a bit, one of the impressions I have coming here is, I'm not quite sure people quite realise what's been achieved so far, because this thing called the ICS, which we're calling the ICS, which is this group of different stakeholders, which Martin and Penny have brought together, and many others as well. Megan, you've been involved in that too, obviously. There's something really quite striking about the partnership. So I think that and the partnership has been able to create a model which has it's very coherent, and also a methodology behind it, which is very well thought through. So I think the model and that coherence won't change, but the way in which that model is applied on the ground, I think will vary. And so I think you will see these golden threads which are running through it. But actually, for these very different local communities, I expect there will be quite significant variation in the components and the way in which things are delivered. But at its heart is something that is consistent and conceptually coherent.
Thank you. Martin, did you want to jump in?
Yeah, I think there's definitely a challenge there, and I think what we'd like to do as kind of the model gets further designed, really, to make sure that people have kind of time to consult and kind of comment, and if there are kind of cohorts of people or particular kind of geographical challenges, we really want to hear that kind of feedback as well. But on the other side, we're also trying to make sure there isn't a kind of postcode lottery. So actually what gets offered in Sussex is offered to everybody in Sussex as well. And also about kind of in terms of, some of the services, but also just thinking about how the commissioning process works as well. So what we're trying to do is make sure that all the commissioning all gets aligned across the 3 areas as well. And it's much more understood, much more kind of consistent and coherent as well for everybody going forward as well.
Absolutely. Martin has got his hand up. Would you like to ask a question, Martin?
Thank you, Megan. Yeah, I mean, firstly, just to thank Martin, Oliver and Nigel for a really clear outline of previous experience and relating that so clearly to Sussex. I think that was really helpful. And then just in relation to Jim's question, I'm absolutely reassured by the answers all 3 have given. Actually, that's really, really helpful to understand the commissioning focus it should be around outcomes for the population. Oliver's acknowledged the need for the likelihood of some variation in how that's delivered based on the history and legacy of each area, which is absolutely appropriate. And Martin quite rightly made that point that the important focus is on everyone having a level playing field in terms of access, avoiding that postcode lottery. So I'm just really reassured by hearing all of that. I just wanted to reiterate my thanks. Thank you.
Thank you, Martin. That's really great to hear. We have got a question in the chat, and we've also got a hand up. I'm very aware of time, so I think that's probably all we'll have time for. But just to say, if anyone does have any other questions, we can obviously still take this offline. So you can send any other questions you have through to the email address that you'll receive the notes from today from. So respond to that, it comes through to me, and I'll make sure that any questions you have are responded to. Jonathan put in the Q&A box. It's been really interesting hearing about how the experience has been for clinicians and for voluntary sector colleagues, but we'd be interested to hear a bit more about how these changes have affected, admin colleagues and, corporate services, support services, and how they were obviously involved in the transformation or perhaps not in some parts. Who'd like to answer that?
I can say a couple of things about my experience. So I think the role seems to be evolving a bit in terms of admin and support. So if we have a shared IT system and much closer communication with GPs, things like clinic letters become less relevant. And so, and however, other things become more relevant, like organising meetings, we're working across different agencies and helping, the logistics of delivering what is actually a more complicated model. And other support services like supporting the development of relationships, I think, and memoranda of understanding when you're working interagencies. There are sort of other complexities, but they're detail and they're not insurmountable, and there are solutions that other people have developed. I think effectively it is a model which will ask everyone to sort of adapt and evolve a bit.
Thank you, Oliver. Martin, was there anything you wanted to add to that?
Yes, apologies. I lost your sound at the end, so we won't just pause in. I couldn't quite hear the end, and I was hoping kind of Nigel and Oliver heard the end of the question as well. But I think it was just around the resources, I believe, wasn't it, Megan? Was that correct?
I guess just how the transformation is being experienced by colleagues other than our clinical and VCSE colleagues, our admin and corporate and support service colleagues.
Yeah, I think we need to acknowledge actually, it will be a journey that we're all on as well, and everybody will have to adapt and change how they work. But I kind of hope that actually people will feel like, or they will experience that's much more of that joined up kind of approach really that Oliver was mentioned as well. And I think we also need to kind of really keep that motivation going to actually we're trying to kind of do something once and do it well. So it might take time, but actually what we get at the end of it is something that we can hopefully all share and be proud of, because I think actually everybody really loves their job and everybody's really committed to it, and I think everybody wants to be proud of what they do as well. So I think we need to, when we're thinking about one team, we are talking about the totality of the kind of the wider sector, and that we all have kind of real pride and ambition for what we're trying to do as well. So it's a really good reminder though around the importance of those roles, and actually making sure that we do really kind of work on, as you're leading, Megan, is around the communication and kind of make sure that they have their say and they have their voice heard as well. So it's a really good reminder. So thank you.
Absolutely, thank you. We've got a couple of hands up, so these will be the last questions we'll be able to get to today. Unfortunately, time has run away with us. So I'm going to come to Carol first. Did you have a question?
Yes, a very quick question, specifically to Martin Dominey, with reference to the presentation around Somerset and the fact that everybody gets something. was this something in terms of statutory services, or did that encompass third sector as well? And I'm thinking especially then following on with the conversation regarding consistency and consistency across Sussex, because things are so different in terms of third sector across Sussex and in terms, well, generally as well, how that could work. Is it some, what, first of all, was it just statutory? Was it statutory or was it both?
No, it's both, Carol, actually, because I think what they did with their locality kind of areas as well. So everybody kind of that wanted to support kind of had these kind of the no wrong door approach. So when there was kind of somebody who was requesting support, there was a kind of quite a wide multidisciplinary team around that could kind of work with the person and work with each other to actually say, actually, well, we think actually this might be a really good, healthy, good starting point for somebody, or actually we might be doing this together, or actually there's an organization that I think that's really, really kind of appropriate for them as well. So over time, they've increased the amount of kind of providers and partners within those teams as well. I think they've gone from funded from 10 to 17 now. So they've brought people who are all kind of delivering kind of mental health, but they're also kind of bringing in other kind of wellbeing options for people as well. So the kind of the menu on options for people is kind of growing kind of year on year as well. So that's why everybody kind of has some support offer, no matter where they are or what their kind of presenting kind of needs are as well.
Can I just flag up one thing around that? How much the person involved actually takes part in that decision making, and if they don't feel that that's what's necessary, how that leads to.
Yeah. So I think when they're kind of the person sort of initially made aware to the team, there's one person in the team that goes back and has those kind of conversations with that individual as well, or whether there's other options to actually for that person to actually meet more people, more partners as well. I'm not quite sure about that detail, but we can find out for you, Carol, as well, and then kind of reflect on that. So thanks for that point.
I think going forward, lived experience representation is going to be really important, especially around those kind of things, to look at those in great detail, but to make sure you get really informed.
Yeah, no, absolutely. A really good point, Carol. Thank you.
Thank you.
Thank you. Just want to come to Mel, as Mel's had her hand up for a while. Mel, did you have a question?
It wasn't my real hand, we're fine. I just wanted to say that talking about joined up response, this is perfect, because in the working together groups, the people participation team, you would actually find that, and this is beautiful, over the times of COVID, patients, staff especially, are working and in harmony. They have much more similarity in what they're thinking and how they want to react, and they're actually very supportive of each other, not guiding each other, and they all have the same questions. And the things you've been talking about, I'm just applauding you quite viciously, because the things you've been talking about are things that are raised within these meetings, and it shows that you're fully hearing, and then not just hearing and nodding, but you're trying your best to address. And if there's anything, because Carol and I go to the same meetings, if there's anything that's possible for us to pass on, then please do let us know, because we're West Sussex, so we've seen this bit, we know it does work, and to continue this approach, I'm just saying it will work, because you showed so much thought in it. So it's a bit of applause.
Thank you, Mel. And I think that's kind of a perfect final thought, really, in that, to kind of reflect on what Martin said about, this is hard stuff, this is challenging, and that's why different parts of the country and the colleagues that we've spoken to have taken this on in different ways and taken different approaches and kind of styles to this. But obviously in Sussex, we are really trying to learn from others that have come before, and to really develop a model that's going to be the best option for our communities, and for the people working in our services and our system. So thank you all so much for attending today, and for Martin, Oliver and Nigel for presenting the session. I really hope that it's been useful for everybody. Next month we'll be back, same time, same place, and we're actually going to be looking in more detail into the clinical model that we have been developing, and would like to share that and start to get some feedback on what people think. So do make sure you register for that. I'll send around the link with all the other supporting notes from today. But yes, just thank you all again for attending and for participating, and do fill in that survey to let us know what you think about this different format, and whether this has worked better for you, or whether you prefer the old way with cameras off. Would be really great to hear your feedback. Mel, have you got your hand up? Final thoughts?
I may cease to be a governor on Friday. We're going to see how it goes. If you're happy with me attending, or just wait and then go, oh God, we've got rid of her, thank goodness. Or, yeah, we'll have her along. She'll forget her lie. So that's the beautiful part about my brain. I'd forget the lie. You only ever get the truth. But only if you wish me to be here. Once you find out the deadly result, then consider sending me an email, but don't if you wish not to.
Mel, you and everyone else who is interested in this work is very, very welcome and encouraged to continue to attend and be part of these conversations and the work going
You're
forward.
recording this, okay, ladies and
Yes,
gentlemen, the
I
public.
absolutely
We've got a
mean it.
witness, or 42.
I absolutely mean it. So thank you all again for attending today, and for your contributions. Sorry that we have overrun, but I think it was worth doing that to be able to obviously fit in some more. But yes, we'll let you go and enjoy the rest of your day, and we look forward to seeing you again next month.
Nigel's written a really nice thing in the caption. Thank you, Nigel.
No, thank you. Thank you very much, everybody.
Thank you.
Bye.
Thanks, everyone.
Bye-bye.